Welcome to the class. Today we are going to discuss management of endometrial hyperplasia. This is Green Top Guideline number 67. It is published in February 2016. This topic is very important from RCOG examination point of view. So today in our session we will discuss only endometrial hyperplasia without Atypia. Okay. So in the subsequent slide we will come to know that endometrial hyperplasia as per WHO classification it is divided into two: endometrial hyperplasia without Atypia, and second is a atypical endometrial hyperplasia. Okay. So out of which we will be discussing only endometrial hyperplasia without Atypia in today's lecture. So this is the executive summary of the recommendations from the GTG number 67. Endometrial hyperplasia is often associated with multiple identifiable risk factors, and assessment should aim to identify and monitor these factors. So there are certain identifiable factors like maybe obesity or high BMI of the patient, or the patient is on HRT. So there are certain identifiable factors which we need to look into it and identify and monitor these factors. Okay. How should the endometrial hyperplasia be classified? So as per WHO revised 2014 classification, it is divided into two groups. Okay. One is a hyperplasia without Atypia, that is endometrial hyperplasia without Atypia. That is the today's topic of discussion. Okay. And second is atypical hyperplasia. Today we will not be discussing atypical endometrial hyperplasia. We will be restricting ourselves to the hyperplasia without Atypia. Okay. What diagnostic and surveillance methods are available for endometrial hyperplasia? So one is the diagnosis and second is the surveillance of endometrial hyperplasia we need to carry out. So what are the methods which are available? So endometrial sampling by outpatient endometrial biopsy. Remember, it is actually a OPD procedure. OPD sample of endometrial biopsy is recommended for diagnosis of endometrial hyperplasia. Okay. Second is a diagnostic hysteroscopy should be considered to facilitate or obtain an endometrial sample, especially where the outpatient sampling fails or is non-diagnostic. Okay. So endometrial sampling is the preferred method on OPD basis. If the endometrial sampling fails or is non-diagnostic, then diagnostic hysteroscopy should be considered to facilitate or obtain an endometrial sample. Next is a transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia in pre and postmenopausal women. But it is a histopathological diagnosis. So ultimately it comes to the endometrial sampling. Then direct visualization and biopsy of the uterine cavity using hysteroscopy should be undertaken where endometrial hyperplasia has been diagnosed within a polyp or discrete focal lesion. So for some reason the polyp is sampled, and in that polyp you find the endometrial hyperplasia. In that particular case you have to go back and perform hysteroscopy to find the endometrial hyperplasia status. Okay. So there is insufficient evidence for CT or MRI or other biomarkers in management of endometrial hyperplasia, and their use is not routinely recommended. So CT and MRI for endometrial hyperplasia is not indicated. Okay. So what is indicated? What we have seen? OPD basis endometrial sampling. Okay. Second is a diagnostic hysteroscopy if the endometrial sampling fails or is non-diagnostic. Third, ultrasound has got some role in diagnosing endometrial hyperplasia, and if you find in the polyp there is a hyperplasia of the endometrial hyperplasia, in that particular case you have to do the diagnostic hysteroscopy to sample the endometrium. Okay. And CT and MRI are not recommended. How should endometrial hyperplasia without Atypia be managed? Now let us come to the management of endometrial hyperplasia where there is no Atypia. Okay. Women should be informed that the risk of endometrial hyperplasia without Atypia progressing to endometrial cancer is less than 5% over a period of 20 years. And the majority of the endometrial hyperplasia without Atypia will regress spontaneously during the follow-up. So what is the risk? These are the SBAs. What is the risk of endometrial hyperplasia without Atypia progressing to endometrial cancer? it is less than 5% over a period of 20 years. Okay, is it clear?
Yes, sir.
Is it clear? Yes, and it is not 5%, it is less than 5%. Okay, because in the option there will not be 5, you will find 3% or 4%, and then you will confuse because there might be 7.5% option, but answer is less than 5%. So if it is a 3% or 4%, you have to select that. Okay, so what are the reversible risk factors associated? Obesity, hormone replacement therapy should be identified and addressed if possible. Observation alone with follow-up endometrial biopsies to ensure disease regression can be considered, especially when identifiable risk factors can be reversed. However, women should be informed that treatment with progesterone has a higher disease regression rate compared to the observation alone. So, the first modality is the observation alone. Okay, that if there are high risk factors which are associated, say for example obesity is there or HRT is there, and you are taking care of those factors, these modifiable factors you are controlling, in that particular case one you can go ahead with a simple observation, but you have to inform that rather than observation, if you start the progestrogens, then it has got a higher disease regression rate compared to the observation alone. Okay, so observation is one modality, but the preferred modality will be progestrogens, because it has got a higher disease regression rate. Okay, so now let us think about the progesterone treatment. It is indicated in women who fail to regress following observation alone or in symptomatic women with AUB. So those women who fail to regress following observation, and those who are symptomatic with AUB, these women you have to start them on progesterone. Okay, now, what should be the first medical treatment of hyperplasia without Atypia? Both oral and intrauterine progesterone, that is LNG-IUS, are effective in achieving the regression of endometrial hyperplasia without Atypia. So, what we have seen, one is a observation is a one way of modality. Second is the progestrogens. Okay, and progesterone has got a favorable profile and a higher disease regression rate. Okay, in the progesterone we have oral progesterone also and intrauterine LNG system or LNG IUS. Now these are the two modalities. One is a continuous oral, and local intrauterine LNG IUS are effective in achieving regression of endometrial hyperplasia without Atypia. The LNG IUS should be the first line medical treatment, because compared with the oral progesterone, it has got a higher disease regression rate, favorable bleeding profile, and is associated with fewer side effects. So what is the first line recommended treatment for endometrial hyperplasia without Atypia? Yes.
Sir,
But
first is
sir, first is
observation that
observation
you reduce the
that you
risk
reduce the
factors,
risk
and
factors,
if not,
and
then you
if
can
not,
give
then you can give
progesterone,
progesterone,
in which it is
in
not
which it is
decreasing
not
with
decreasing with
observation alone.
observation alone.
They are of two
They are
types:
of two types:
local and
local and
local
local
intrauterine and oral.
intrauterine and oral.
Local
Local
intrauterine involves
intrauterine
LNG
involves
IUS.
LNG-IUS. Yeah. See, LNG-IUS is the first line treatment which is recommended for endometrial hyperplasia without Atypia. Remember,
Yes, sir.
endometrial hyperplasia, the first line treatment in cases of without Atypia is the LNG IUS. Okay, observation, this modality is available, but thing is that progesterone has got a better regression profile as compared to the observation alone, and that is why what is first line treatment is a LNG IUS. Okay, LNG IUS should be the first line medical treatment, because compared with the oral progesterone, it has got a higher disease regression rate and more favorable bleeding profile. It is associated with the fewer adverse effects. Continuous progesterone should be used, that is 10 to 20 milligrams of medroxyprogesterone or norethistron 10 to 15 milligrams per day for women who decline LNG IUS. So you can go with the continuous progesterone oral treatment also, But first line of treatment will be LNG-IUS. Then comes the oral treatment. Okay, in oral treatment you can use medroxyprogesterone acetate, that is 10 to 20 milligram per day, or you can use norethistone 10 to 15 milligram per day, especially for women who decline LNG-IUS. So first modality is going to be LNG-IUS. If the woman declines LNG-IUS, then you can give oral progesterone for 6 months. Okay, so cyclical progesterone should not be used because they are less effective in inducing regression of endometrial hyperplasia without Atypia compared with the continuous progestrogens or the LNG-IUS. Okay, so you need to give a continuous dose of progesterone, not only in a half cycle or the second half of the cycle. Generally they give cyclical dose. It is not recommended for the treatment of endometrial hyperplasia without Atypia. Okay, so you have to give continuous oral progesterone, especially for women who decline LNG-IUS. Then what should be the duration of treatment and follow-up of hyperplasia without Atypia? Treatment with oral progesterone or LNG-IUS should be minimum for 6 months in order to induce histological regression of endometrial hyperplasia without Atypia. So how much treatment should be given? Minimum 6 months will be required for the changes of regression to be seen in cases of endometrial hyperplasia without Atypia. If adverse effects are tolerable, fertility is not desired, women should be encouraged to retain the LNG-IUS up to 5 years, as this reduces the risk of relapse, especially if it elevates the abnormal uterine bleeding symptoms. So minimum 6 months is the recommended treatment. But if a woman is given the LNG-IUS, then you have to encourage the lady to use it for continuously for 5 years, because it has got a risk of relapse is very less. If that LNG-IUS is continued, the risk of relapse is less. Okay, now how should be the endometrial surveillance? Once you have given the progesterone now, okay, if you give oral progesterone, you have to stop after the 6 months. But if you are giving LNG-IUS, you will encourage the patient to use it continuously for 5 years, because it will reduce the risk of relapse. Now you have treated this endometrial hyperplasia without Atypia with progesterone. Then what surveillance we are going to carry out? It is a outpatient endometrial biopsy. Okay, outpatient endometrial biopsy is recommended after a diagnosis of endometrial hyperplasia without Atypia. Endometrial biopsy should be arranged at a minimum of 6 monthly intervals, although review schedule should be individualized and responsive to the changes in a woman's clinical condition. At least 2 consecutive 6 monthly negative biopsies should be obtained prior to the discharge. Okay, so what is the surveillance method? It is a OPD basis endometrial sampling. Okay, at 6 monthly interval, and if you get 2 6 monthly negative samples, then you can discharge the lady from the follow-up. Okay, so initially you have diagnosed the endometrial hyperplasia without Atypia. You started them on progesterone, okay, LNG-IUS or oral progesterone. In that particular case, what will you do? You will carry out the 6 monthly endometrial biopsy, and if you get 2 endometrial biopsies which are negative, that means for 6 months, and she can be discharged from the follow-up. However, if the patient is taking oral progesterone, we will give only for 6 months but continue with the surveillance annually. Is it clear,
Yes, sir.
Dr. Amrita?
Yes, sir.
See, we have diagnosed endometrial hyperplasia without Atypia. Then
Yes.
we started with the progesterone. The first line LNG-IUS. Minimum 6 months is recommended, but LNG-IUS is to be recommended for 5 years.
5 years.
Okay, then we will do the 6 monthly endometrial biopsy. If we get 2 6 monthly endometrial biopsies negative, in that particular case we can discharge the patient from follow-up. However, if we have given oral progesterone, we will give only for 6 months, and that patient will not be discharged, but that patient will be on a continuous annual follow-up after 2 negative biopsies. You got it?
Yes, sir.
Yes, sir. So two negative biopsies at 6 monthly interval. Oral treatment will be annual follow-up. LNGIUS will be discharged from the follow-up. You got it?
Yes, sir.
Is it clear, Dr. Sansi?
Yes, sir.
Yes, sir. Okay, women should be advised to seek a further referral if abnormal bleeding recurs after completion of treatment, because this may indicate the disease relapse. So if there is a further AUB like picture after the treatment, then it is nothing but the relapse and she should be given a referral advice. So in a woman at a risk of relapse, or if there is a BMI of more than 35 or equal to 35, or those treated with oral progesterone, 6 monthly endometrial biopsies are recommended. Once two consecutive endometrial biopsies have been obtained, then long term follow up should be considered annual endometrial biopsies. Okay, so once you have got two consecutive negative endometrial biopsies, in that particular case you will continue with annual endometrial biopsy. One, if the lady has got a BMI of more than 35, or if she is treated with oral progesterone.
Oral
Remember,
progesterone.
here there is a catch. Okay, you have treated the you have treated your patient with LNG-IUS. Okay, in LNG-IUS you have got a 6 monthly follow-up. Two biopsies are negative. Then what will you do?
Discharge the patient.
Discharge the patient. Provided her
Her BMI
BMI
is less
is
than
less
35.
than 35. Did you get it?
Yes, sir.
If the BMI is more than or equal to 35, or if she is given an oral progesterone, then 6 monthly biopsies are recommended. Two negative biopsies will be followed by the annual endometrial biopsy. Okay, so even if she accepts for LNG-IUS and her BMI is more than 35, then the treatment of or the follow-up of choice will be annual follow-up after two negative endometrial biopsies taken 6 monthly. Is it clear?
Yes, sir.
Yes, sir. Okay, so in the examination you will be given multiple options: 6 monthly follow-up, 3 monthly follow-up. Okay, two negative biopsies discharge, one negative biopsy discharge, two negative biopsy at 6 months. If they are negative, then patient to be discharged. Then you have to see what is the BMI of the patient and what is the kind of treatment you have given. If the patient has taken oral progesterone, then the surveillance will continue. Okay, annually after two negative biopsies which are taken 6 monthly. If the patient has taken LNG, there is no high risk factor for risk of relapse such as BMI more than 35. In that particular case she will be discharged. Okay, so now when is the surgical management appropriate for women with endometrial hyperplasia without Atypia? So what kind of surgical management is appropriate and when it should be offered for endometrial hyperplasia without Atypia? Up till now what we have seen, endometrial hyperplasia without Atypia, so there is no surgical management, there is a medical management. Okay, but
Yes, sir.
when the surgical management is indicated, now this slide tells about the indications for surgical management such as hysterectomy. Okay, so hysterectomy should not be considered as a first line treatment for hyperplasia without Atypia, because progesterone therapy induces histological and symptomatic remission in the majority of women and avoids morbidity associated with the major surgery. Okay, so what is the crux here to understand? Majority of the patients will respond to the progesterone treatment. Okay, and hence hysterectomy is not recommended as a first line treatment for hyperplasia without Atypia. Okay,
Yes,
now
sir. Yes, sir.
hysterectomy is indicated in women not wanting to preserve their fertility when one, progression to atypical hyperplasia occurs during the follow-up. So you have started them on progesterone, but during follow-up there is a progression to the atypical hyperplasia or there is a progression to the endometrial carcinoma. Okay, in that particular case you have to go for hysterectomy. Then second is that there is no histological regression of hyperplasia despite 12 months of treatment. So what we said, 6 monthly two biopsies should be negative. So we are monitoring this our patient for 12 months, but there is no regression. Okay, first biopsy taken, it is negative. second biopsy taken, if it is positive, that means there is no regression. Okay, then you have to consider hysterectomy. Okay. Third, there is a relapse of the endometrial hyperplasia after completing the progesterone treatment. Patient was started on progesterone, responded, but again there is a relapse in because we are going to keep them under surveillance. Okay, so if there is a relapse, then what we will do, hysterectomy. Okay, there is a persistence of bleeding symptoms, there is no clinical response, that means AUB is persistent, then hysterectomy is indicated. And last is a women declines to undergo endometrial surveillance or comply with the medical treatment. That means there is no compliance to the medical treatment, or she declines the endometrial surveillance. Medical management, if you give, then it has to be under surveillance till the patient is discharged. Okay, and you know the discharge criteria. Okay, so if the patient is not willing for that, then the hysterectomy is indicated. So have you understood the indications for hysterectomy? One, there
Yes,
is a
sir.
progression. There is a progression. Then second, there is no regression. Third, there is a relapse. Fourth, there is a persistence of the symptoms. And fifth, women declines the follow-up or the surveillance, and there is a compliance issue. These are the indications for hysterectomy in cases of endometrial hyperplasia without atypia. Okay. Then what kind of surgical management is there? So postmenopausal women who require surgical management, they should be offered bilateral salpingo-oophorectomy together with the total hysterectomy. So if the lady is postmenopausal, in that particular case, along with hysterectomy, you will advise them to undergo bilateral salpingo-oophorectomy. Okay, but if she is a premenopausal, then decision to remove the ovaries should be individualized. However, bilateral salpingectomy should be considered, as this may reduce the risk of future ovarian malignancy. So if it is a premenopausal lady, then removal of ovary is to be individualized as per the case. Okay, however, what you have to remove is the bilateral tubes, or the bilateral salpingectomy should be considered, as it will reduce the risk of future ovarian malignancy. Then what kind of approach is recommended? A laparoscopic approach to total hysterectomy is preferable to an abdominal approach, as it is associated with a shorter hospital stay, less post-operative pain, and quick recovery. So laparoscopic method is recommended. So if you are given an option, then you will always select the laparoscopic approach. Okay, so most of the options will be confusing, so you have to see to it that what is the best in that particular scenario. One, whether it is a medical management or surgical management, then what kind of medical management we are offering. Okay, like LNG IUS we are offering, or oral progesterone we are offering. Then what kind of surveillance we are going to do, when we are going to discharge, what are the high risk factors which are involved, and accordingly you will select the appropriate option from the given options. Okay, so this is the same thing we have seen here. Now we will see only the left side, where there is a endometrial hyperplasia without atypia. The right side is a atypical hyperplasia, that we are not going to discuss today. We are going to discuss only endometrial hyperplasia without atypia. So first thing what we have to do is the address the risk factors which we have seen. If there is obesity or HRT, these risk factors are to be addressed. Then observation is a modality which is available. However, progesterone treatment is preferred. In that, first line is a LNG IUS, second line is a oral progesterone. Is it clear?
Yes, sir.
Yes, sir.
So look at the flow chart. On the left side, there is endometrial hyperplasia without atypia. We are going to address the risk factors. Observation is a one modality which is available, but the preferred first line is a LNG IUS, second line is a oral progesterone. Now on this treatment, okay, on this treatment, surveillance is indicated. In cases of endometrial hyperplasia without atypia, it is a 6-monthly surveillance. Okay, EH is a 6-monthly, AH is a atypical. Atypical will require 3-monthly. That we are not going to discuss today. Okay, so endometrial hyperplasia surveillance, endometrial biopsy 6-monthly, and in this biopsy, what we are going to find? One, there can be regression, there can be persistence, or there can be progression. So these are the outcomes which you can get in the surveillance. If there is a regression, persistence, or progression. If it is a regression, then in that particular case, if it is a LNG-IUS, we will continue the treatment for 5 years. If it is a oral progestogen, we will stop the treatment after 6 months. And if the patient is having ongoing AUB, in that particular case, total hysterectomy, SOS BSO, not all cases BSO. If she is a postmenopausal, we will go ahead with the BSO. Premenopausal, we have to individualize the case. Is it clear? Is it clear?
Yes, sir.
Yes, sir.
Okay. So next is a persistence. Now, if there is a persistence, the endometrial hyperplasia persists. In that particular case, we will review the treatment. In cases of endometrial hyperplasia, we will start the medical treatment if she is on observation alone. Okay. That means observation has failed, then we will start with the medical treatment. Okay. And advise total abdominal hysterectomy plus minus BSO if persistence after 12 months of medical treatment. Okay, so if she is not on any treatment, in that particular case, we will start her on oral progestogen or IUS. IUS will be the preferred. Okay, so what kind of scenario it is? You may be given the lady who has not opted. Initially, she has declined the progestogen treatment and she preferred to have observation. Then during surveillance, it was noted that her endometrial hyperplasia is persisting. In that particular case, what is required? Because she was on observation, we will start with the medical management. If she would have been on the medical management and the endometrial hyperplasia is persisting more than 12 months, then we will go for hysterectomy. Okay, is it clear?
Yes, sir.
Yes, sir.
Not on treatment, then we will put on progesterone, progestogen. If she was on progestogen already, then advise total hysterectomy plus minus BSO. Okay, and if persistence after 12 months of medical treatment, we will go ahead with the TH plus minus BSO. Okay, and if there is a progression, we will review the treatment. If there is a atypical hyperplasia, in that particular case, total hysterectomy plus minus BSO is indicated. If there is endometrial carcinoma, then we have to manage as per the protocol. So if there is a progression, no doubt you have to go ahead with the TH plus minus BSO. If there is a persistence, in that particular case, you have to analyze whether the progesterone was given or not. If the progesterone not given, give the progesterone. Okay. If the progesterone given but failed, then she will go for TH plus minus BSO. Okay. Now see the regression. What we have seen in the first column, regression. LNG-IUS is given. We will continue for 5 years. Oral progesterone will stop after 6 months. And if the symptoms are present, then in that particular case, total hysterectomy plus minus BSO. Now here, after that, we have to continue with the follow-up. If it is an endometrial hyperplasia and BMI is less than 35, if there are 2 consecutive negative endometrial biopsy at 6 months interval, if the BMI is less than 35, 2 consecutive negative biopsies at 6 months intervals, then patient will be discharged. If the BMI is more than 35 or treated with oral progestogens, in that particular case, 2 negative endometrial biopsies at 6 months intervals, thereafter annual endometrial biopsy. Okay. At any time if there is a relapse, she will be advised total abdominal hysterectomy with bilateral salpingo-oophorectomy. Okay. So you have to understand the scenario, what exactly the scenario is. Okay. Now in the lower side there are certain notes. Those notes are also important, so I have made a separate slide for those notes, out of which point number B and point number F, they are very, very important. I will just read those. First, point number A mentions that the risk factors for endometrial hyperplasia are obesity, HRT regimens, tamoxifen therapy, and ovulation. These are the high risk factors one need to think of. Okay, we need to address these factors. Second, consider ovarian conservation according to the age, menopausal status, and patient preferences. In addition to non-regression of endometrial hyperplasia, persistence or AOB symptoms following non-surgical treatment, a total hysterectomy may be indicated where there are adverse effects associated with the medical treatment, concerns over the compliance with the treatment or follow-up, and patient preferences, example high levels of anxiety. So this is very important because sometimes in your scenario it is mentioned that the patient has declined the follow or patient is non-compliant, okay, or the patient doesn't want the medical line of treatment. In that particular case we may have to go ahead with a total hysterectomy, okay. Or if there is a high level of anxiety, in that particular case also total hysterectomy may be indicated where there are there are adverse effects. So she has opted the medical treatment but there are adverse effects of the medical treatment, or there are concerns over the compliance with the treatment or follow-up, and third is a patient preference such as high level of anxiety. If these are present, then we might have to offer the total hysterectomy even in cases of endometrial hyperplasia without Atypia, okay. Then they have given the definition, that is regression, that is non-hyperplastic or non-malignant endometrial sample, or then they have mentioned about the persistence, that is no regression or progression of initial endometrial hyperplasia, okay, after 3 months or more months, and progression means development of atypical hyperplasia or endometrial carcinoma. So these are the things or these are the outcomes for the surveillance, okay. Then come to the point number F, in which what is mentioned, start medical management if endometrial hyperplasia are not treated initially. The decision to persist with medical management should be taken after careful consideration and thorough discussion with the woman regarding the risk and benefits of prolonged medical treatment compared with the total hysterectomy with or without BSO. Persistent beyond 12 months is associated with a significant risk of underlying malignancy and a high risk of failure to regress, such that a total hysterectomy with or without BSO should be recommended. So you have to counsel the patient if the endometrial hyperplasia is persisting more than 12 months. In that particular case the risk of progression is high, okay, and that is why their total hysterectomy with or without BSO is recommended. So these are the certain points from the these notes, okay. So that finishes the topic of endometrial hyperplasia without Atypia. Is it clear?
Yes, sir.
Okay.
Yes, sir.
So endometrial hyperplasia, the progesterone, especially the LNG-IUS, is the first line of treatment, okay. Thank you. If she is using the LNG-IUS, she should be